Hey, good morning. Dr. Hammond here. We're going to do a little education about C-collars, soft versus rigid versus not using them, kind of the history a little bit, and kind of where we land for our department and where we want to go with this. So appreciate you guys paying attention, and really should probably only last about 20 minutes or so. So share this with you. Okay, so here's some of the old assumptions about spinal immobilization, right? So we always thought that, patients with cervical spine injury could have, unstable cervical spine fractures or injuries that we were going to make worse. And the thought of moving them could potentially make their fracture or whatever injury they had in their cervical spine worse just by moving them. And that the thought was that rigid C-collar would basically prevent harming, further harm with the cervical collar. Whether that's the case or not, we'll kind of look at here in a few minutes. And the other thought was basically it's harmless to put a C-collar on somebody, and so we could do it to anybody and everybody involved in any kind of trauma with neck pain. So kind of the old assumptions about how we used to manage cervical spine immobilization. Where the real basis comes from of who do we, so we're kind of work backwards here. So there's the Nexus criteria and the Canadian C-spine criteria, or Canadian C-spine rule, that basically help direct you and a physician in the emergency room on if they're going to get imaging of somebody's neck involved in a trauma. So that's really where this came from, is who's going to get radiological studies involved in traumatic injuries of the cervical spine, not who gets a C-collar in pre-hospital setting. But we can kind of work backwards on the thought process of that. So let's address it from this point of like an imaging study first, and then we'll work backwards to who gets a C-collar or who doesn't. So Nexus criteria, first off, patients have to be alert and stable, right? So your unstable multi-system trauma patient, Nexus doesn't apply. Patients can't have any neurological deficit, which can be the full spectrum, right? So paresthesia in their left hand, that's new, and it's, my left hand is numb and I can't feel it, or pins and needles even, where they can feel it when they have sensation, but it feels different, right? So the pins and needle sensation, almost like when you hit your funny bone, right? And so you can still feel your hand, but it's something's off. So any neurological deficit is a positive, and those people would get imaging in the emergency room. They can have no altered level of consciousness, including they cannot be intoxicated, because an intoxicated patient doesn't give reliable history and doesn't actually provide a reliable examination, right? So, so they're off the list. And if there's any midline spine tenderness, so on the spinous process in the back of the neck, when you palpate, midline and push on the bones, do you push on those and does it hurt? And is there no distracting injury, like an open tib fib fracture or something like that? So those are your criteria from Nexus on who would get imaging and who would not get imaging, right? So basically they say you can clear somebody by Nexus criteria if they meet all of these things. If they're alert and awake, if they have no deficit, if they're not intoxicated, they're not altered, they have no tenderness, and there's no other injury, you can say basically that they don't have I would say a bony or abnormality of the cervical spine. They may have muscular, but that's going to rule out kind of spinal injury itself. So let's look at the Canadian C-spine rule, which really talks more about mechanism and who's going to get radiological imaging, not who's going to get a C-collar, but we'll work there. So they're, again, they start off at the top there with a GCS of 15 and stable, just like the Nexus criteria. And then they put high risk factors here. So here's basically three pieces that they consider high risk. And that is, if you're over the age of 65, you're more likely to get imaging in the emergency room because of basically osteoporosis, and things have just kind of worn down over time. And so they say over the age of 65, you should be imaging more patients for sure. Does that mean I image anybody with neck pain over the age of 65? Probably not, but it puts it on my radar of just that, right? So you're older generation, more likely to get imaging, maybe more likely to get put in a C-collar as well. High risk, another high risk factor, dangerous mechanisms. So they define these as falls, more than 5 steps, motor vehicle collisions involving, over 60 miles an hour with ejections or rollovers, anything that's going to be a high mechanism of injury in an MVC. They also add to that axial load, so like a diving injury into a pool where you hit directly on your head, more, much higher likelihood of having some kind of a cervical spine injury. And then they also add any of like the ATV accidents or bicycle accidents as well are high likelihood to have a cervical spine injury. And then the other high risk criteria they put on there is paresthesias again, so neurological deficits. So that is about, you see the arrow over to radiography. Sorry, I can't see it over here. So any kind of imaging based on age, high mechanism of injury, or neurological deficit. Also, probably the people who should get a C-collar pre-hospital, and we'll talk about how to, where we're going to go with that. Your low mechanism of injury or your low risk factors for patients with neck pain on this Canadian C-spine rule is rear end MVCs. We all know very unlikely to have any kind of a significant cervical spine injury. The caveat to that is if it's a rear end MVC at high speed or by a semi truck or bus or something like that. Anybody, they say sitting in the emergency room, sitting upright is fine. It's a low likelihood of an injury. If they're ambulatory at the scene, low likelihood of injury. Neck pain that occurs delayed, right? So there's no neck pain at the scene, and 2 hours later in the emergency room they have neck pain. Not likely going to be a cervical spine injury, just musculoskeletal. Do they warrant an imaging study or not? And then the absence of cervical spine tenderness on the spinous process posteriorly. And then the other one is down at the bottom, if they can move their head 45 degrees in both directions, they don't need any imaging. So that's the two kind of rules that we use in the emergency room to clear somebody from a C-spine injury and whether they're going to get imaging or not. And we'll kind of use these to develop what we're going to talk about with the rest of it. So one of the studies that we looked at was in Maine. They went to basically using the Nexus criteria, and if you're alert, you had no deficits, you're not drunk, and you have no posterior midline tenderness in your spine, they basically cleared people to not need spinal immobilization pre-hospital. And so that reduced their amount of spinal immobilization by like 50% just by using the Nexus criteria. And it basically missed one patient in 32,000. So it reduced immobilization in 32,000 patients. And then there was one that was missed that was an unstable fracture. So not bad numbers by any means. Nexus doesn't apply to penetrating injuries, right? So we're talking about whiplash injuries, falls, traumas from a, it's not truly a blunt standpoint, but it's a non-penetrating injuries. Because in penetrating, you're not worried about the spine, right? There's so much stuff otherwise here that you need to deal with more than worried about their cervical spine, as they're probably hemorrhaging, and they're not really likely to have some kind of cervical spine injury in association with stabbing or gunshot or something. So again, some of the older thoughts on this basically is, if somebody injures their spine and, let's just say a fall, right? So we looked at let's say a 10-step fall and somebody goes down the stairs. Is it more likely that us arriving and moving their neck is going to worsen their spinal injury? And it turns out, basically, if you think about what the body is smart to do, is when you have an injury, it protects itself. And so does us moving them or rearranging their head or putting them in a C-collar, does it actually potentially worsen their injury? Turns out the data really has never kind of shown that. I think we all think about it, and I think about it for sure, and it's something that I consider in how I evaluate somebody who's been in a trauma. But the reality is we're probably not worsening any cervical spine injury by movement in relative terms, right? We try to stress these people's heads. not gonna, it's a different story, but relative normal conservative movements were probably not worsening people's cervical spine injuries. It's impossible to immobilize the C-spine without immobilizing the entire body, right? So we do, we put a soft collar or a rigid collar on somebody, but the reality is if they're moving any part of their body, their neck is still moving, right? It's all connected. You can't isolate one piece. So unless we do like what we did in years ago and full immobilization on a hard backboard, like it's just, you can't really immobilize the C-spine fully. They even did a study when they look at the halos post-operatively from neurosurgery patients, that even when you drill a cervical spine immobilizer into your skull and on your neck, like you can still move about 4 degrees. So even still with the most rigorous, piece of equipment to immobilize your C-spine, it's still getting some movement in there. This was another study. Basically, they used the Aspen collar, which is a little more, it's the one that you see people going home with after neurosurgical stuff. So it's an advanced collar, but not like the Halo. Still has significant amount of movement in with it. And so this guy basically wrote that cervical spine immobilization is a myth, and it's probably true. So here's potential dangers, right? So C-collars interfere with airway stuff. So when we did that case not too long ago with the mannequin that fell off the scaffolding. So putting a C-collar on somebody who's hemorrhaging or who needs an airway, are we more likely to injure their spine by moving them or trying to get a C-collar, or are we more likely to miss an airway problem? And it said basically in this study that they read, it's never been documented where there's a case of endotracheal intubation that has caused or worsened a C-spine injury. Does it happen? Probably, right? I mean, if we're going to crank somebody's head back when we try to intubate them as we, hyperextend them, certainly a potential to cause more damage. But the airway, again, still more important than the C-spine injury initially. We talk about rigid collars. They can increase intracranial pressure. The problem is most patients with cervical spine injury often will have a head injury, right? The two are connected. And so are we putting a rigid collar on creating, increased intracranial pressure? Not something we can measure, but just something to think about, I guess. Here's the idea of this, the rigid C-collar and what it does at the higher levels of the cervical spine. So I always think about the rigid C-collar as certainly providing better stabilization of somebody. But the potential harm that occurs in a rigid collar versus a soft collar is that, it's resting on their, shoulders basically, and then up into just underneath their jaw. And it causes some distraction, right? So you're elongating the spine to some degree, and you can actually kind of separate C1, C2 area and cause worsening damage by putting a hard collar on somebody. Whereas a soft collar, really doesn't do that. So other harms from rigid C-collar, whatever, if you wear them too long, they cause pressure sores. Patients don't like them. And just by the fact of having a rigid C-collar, physicians are more likely to order imaging than not when compared to a soft collar. This was a study, they looked at, it was in pediatrics, and basically it said that children that showed up with cervical spine immobilization from a trauma were more likely to get imaged, were more likely to be admitted, and more likely to stay in the hospital. We're longer in the hospital than when pediatric patients arrived without immobilization. So just by the fact of having some kind of immobilization on their cervical spine tends to lead physicians to ordering more tests or doing more things. And then there's the soft collar. So what does the soft collar actually do? Probably nothing, right? I mean, mechanism-wise, not much of anything. So, but it does provide you as a reminder, right? It's the reminder to not move your neck. So again, a soft collar, you have to be somewhat alert, probably not intoxicated, and have a low mechanism of injury, or even a high mechanism of injury, but it's not going to do anything for you. It's going to provide as a reminder for that. So compared rigid collars to soft collars, the soft foam collars, when they do the flexion, extension, all the range of motion of the neck, basically the rigid collar does provide a greater limitation in all those range of motions, but it wasn't as significant as one would think compared to a soft collar, right? Because a soft collar still, it's in your way and it's a reminder. And so the rigid collar is better, but not so substantially better or significantly better. Let's talk about this one. So there's the other idea of, should we not even move people's necks who are found in a certain position with neck pain, right? So the fall and the guy, stuck kind of looking to the right, who says his neck hurts. We could immobilize him in the kind of the presenting injury, right? Versus trying to move his neck and then put him in a C collar or something like that. And I like that idea, I would say. So that just kind of some history and background. So let's just talk a little bit about this. Let me close this window, change. This one better. So what do we do, right? So I would tell you there is no, it's not black and white. So it's all patient dependent, it's mechanism dependent, it's risk factor dependent. So the way that I practice is, if you have a elderly patient from, our local nursing home who's got a history of metastatic bone cancer, like they're going to get imaging, right? So if they're going to get imaging, you should probably think from a pre-hospital standpoint that there's a higher risk that somebody is going to have a spine injury, whether it's a fracture, subluxation, or something in their cervical spine, and immobilize them, properly. So you can't fit a rigid C collar on every elderly little lady in our nursing home, as they have no neck. And so even if you wanted to, you couldn't put a rigid C collar on them. Half the time you can't put a soft collar on them because it just doesn't work. And so you make something up where you give them some reminder with towels and tape or whatever you do. I don't want to create, a defined absolute protocol of who does this and who does that. I want you guys to think about the mechanism. I want you to think about risk factors and then make a decision on how you're going to immobilize them properly. And if you're, more concerned, and the more concerned you are, should lead you to do more immobilization with whatever means at your disposal. So it's a rigid collar, the soft collar, the towels, however you want to work that, I think is perfectly fine. I think it has to be more thoughtful than a protocol of direction. So go back to my high risk factors. So mechanism of injury to me is pretty big, right? So rollover MVCs and intoxicated people are really high risk, right? Because they're not going to show you symptoms. They're going to be altered, and they're probably going to be already self-extricated walking around. So they could meet some of the criteria not to image or immobilize, but the reality is it's a poor exam, and it's not, you're going to miss things. So I think in high mechanism of injuries, altered patients with trauma, we got to lean towards doing something more. And I'm not saying the soft C collar doesn't work, but in an intoxicated patient, it probably doesn't, right? Because they're agitated or whatnot. And so just finding the best way to immobilize them, I think, is probably the right thing to do. And the right thing is really patient dependent and provider dependent. So however you work that out, I think is the right way to do it. The other high-risk patients are definitely cancer patients. So especially metastatic cancer patients who have bone cancer or something, you think a lot more about fractures in their cervical spine from simple falls. And hard C collars are really painful on some of the elderly patients who fall. So again, I like the soft C collar, but maybe with a little bit more reminder. So soft C collar and tape and towels or something like that. And then ATV accidents are always, the problem with motorcycle ATV, the helmet protects their head really well, but it provides a weight, right? And so you're more likely to see cervical spine injuries in some of these ATV accidents. And so again, thinking about a higher, mechanism of injury for potential injuries. I think that's all I got. So there's no answer here, right? So I'm not giving you a direct, use a hard collar, use a soft collar, use towels. Those are just at your disposal. So use at your disposal what you think is the most appropriate in considering the mechanism, in considering, I would say neurological deficits are huge, right? So if there's a new neurological deficit, those patients, don't care how you immobilize them as much as just immobilizing them, because we know that's the key factor, not really how we do it, but that it is done, and it's done well with a reminder, somebody sitting next to them and holding their head. It doesn't matter. It's something that we just have to have them, quote, immobilized, even though it doesn't actually work. So that's all I got. So sorry, there's no direct answer of black and white, but that's how medicine tends to work. If you have questions, it'd be nice if we could do this in person and we could talk about it. And I'm sorry we can't do that as of yet, but we're working towards that. So if you have questions, get them to Captain Pacheco, and I'll address them in our next month's education as well. So thanks for paying attention.